Okay, starting Chapter 9, Patient Assessment. Yes, I know you've already done the questions and all, but you're going to do the packets, and we're going to be doing nothing but patient assessments. Okay, thing you need to remember about patient assessment is it is the cornerstone of everything that we do. From scene safety, when we're rolling up on the scene, to scene management. We could teach you all day long how to run a scene, but we got to do it in an organized fashion. Granted, some of the stuff that you're going to be doing with the patient assessment is going to be mixed up. That's just the nature of emergency medicine. You get on scene, you may get one thing ahead of the other. That's okay. But the biggest thing about patient assessment is that we have an organized thought process that we can refer back to if we think we have missed anything. That way we're double checking ourselves, making sure that we've done everything that we can do. Primary assessment, level of consciousness, ABCs, airway, breathing, and circulation. If we don't take care of the basic problems first, some of our more advanced stuff doesn't mean anything. History taking, making sure that we get a good history of the mechanism of injury and the nature of the illness. And also doing a secondary assessment and reassessing. Just because we fix somebody doesn't mean that they stay fixed. Thing you need to remember with EMR, you're the first trained emergency medical service person on scene, whether it's here at the school or it's out on the roadway. Performing a scene size up. As you're pulling up on a scene, if it's a house, you're checking for any hazards. Does it look like it's all dark if it's at night? Why isn't there a porch light on? Why isn't somebody standing out there calling you in? Making sure that your scene is safe. If you're rolling up on a vehicle accident, making sure that your scene is safe as far as, do you see any smoke? Do you see any wires down? Do you see any kind of hazards that are going on? Do you see anything like someone attacking someone? That is all part of your scene size up. Also, with scene size up gives you a pretty good idea how many patients you're dealing with. Is it a bus full of people, a van full of people, or just a car with a couple people? Is it a house full of people? You may walk into a house where you were told you had one patient, but yet you walk into 5 patients. Performing your primary assessment, getting a good assessment on that patient, involves your airway, your breathing, and your circulation. Getting a good patient medical history. If you can't get the medical history on the patient, maybe you can go through their wallet or through their purse or ask bystanders. Doing your secondary assessment, making sure that you go back and you check for other injuries, and then performing your reassessment. If you fix something, make sure it stays fixed. Some of the skills and knowledge presented in this chapter follow an assessment-based care model. The treatment is rendered based on the patient's symptoms. And the treatment is rendered based on our skill level. Me as a paramedic, I can perform EKGs, I can do cricothyrotomies, I can start IVs, I can do all kinds of things. As an EMR, if I'm not being paid as a paramedic, I am at the level of an EMR, which means I can't start an IV unless I'm on duty. I can't do any kind of surgical procedures unless I'm on duty. So I'm at the level of an EMR when I am off duty. Assessment-based care requires that you conduct a careful and thorough evaluation. When I evaluate the patient, is the patient having trouble breathing or are they not having trouble breathing? That's going to determine, am I putting the patient on oxygen and am I not putting them on oxygen? The patient assessment is a sequence. Again, like I said, we can't teach you to do a patient assessment if we have it all over the place. But I can teach you to do a patient assessment if you memorize that patient assessment in an organized fashion. Keeping in mind that a lot of things that we do are going to happen all at once. When I get dispatched on a call, I don't think about my BSI because I've already got all of that on. I got my gloves on, I've got my glasses on. Once I get on scene, I determine, do I need respiratory protection? Do I need splash protection? Taking care of checking for a pulse. I'm getting pulse with skin color, condition, temperature, and I'm getting level of consciousness on a patient. So I'm kind of doing things all at one time. When I approach the scene, is it nice and safe? Determine that I need additional help. If I've got 1 ambulance and 10 patients, obviously I need more help. Examine to make sure the patient determines if the injuries or the assessor illness are present. So I've got to put hands on the patient. Never get caught standing there with your hands in your pockets for 2 reasons. First, Your hands need to be on your patient, getting skin color, condition, and pulse. And also, if the patient has a good radial pulse, you know they've got a good blood pressure. If you're talking to them, you know their level of consciousness is good. The other thing is having your hands out of your pockets so that you can protect yourself should something go wrong. Obtain a good medical history from the patient. And once you've done everything you can do and you've gotten all the information you can do, once EMS arrives on scene or the fire department arrives on scene, you have to turn around and give a patient report. So you have to tell them what you saw, what you did, what your findings were, how you fixed something, and what was the result of you fixing it. Also giving the patient's personal information to the responding agencies. It's kind of an overview of the surroundings. When you review your dispatch information, location of the incident, make sure you know where you're going if you're being dispatched. Main problem or type of incident. But keep in mind, just because you were dispatched to a cardiac does not mean you're going to roll up on a cardiac. You may get sent to a man down, and it's a man down because he was electrocuted, or a man down because he was shot, or a man down because he had a heart attack. The number of people involved. You may get told there's only one, but you actually end up finding out that there are several. I've had that happen before, where go on a scene for difficulty breathing and I got 25 people coming at me because they were all exposed to hydrochloric acid or some kind of respiratory inhalant. So you have to look at the safety issues on your scene. Other factors that can affect your actions: time of day. If it's a time of day where you're trying to run an emergency call, say by the high school at 2 o'clock, obviously traffic is going to be horrendous, so you may need to alter the way that you're going to that emergency call. Also, the day of the week. Sometimes days of the week, an area may be busier than another area. An area may be open. For instance, an example, Georgia Street. During the day, it's closed during the weekday, unless it's in the summertime. In the summertime, it's usually open. People can go through our stadium parking lot because that actually is part of Georgia Street. During the school day, it's closed. On the weekends, it's open. So if you don't know that, you may actually end up driving up to a fenced area that you can't get through. Weather conditions. Knowing what areas of your city or your area flood when we have some of our sudden rainstorms. Mentally prepare for other situations you may find. So you start thinking ahead, well, what if this happens? What if this happens? What if this happens? Once you've practiced it mentally, it becomes second nature. It's just like when we practice our skills. It all becomes second nature to us. If you come across a medical emergency, contact dispatch using your two-way radios, if you happen to have a two-way radio. Again, ensure your scene safety. We always want to park our vehicle so our vehicle is being used to block traffic that's not going to hit us. We want to make sure that it hits the apparatus or the ambulance before it hits us. We've had lots and lots of people hurt. We've had lots of people killed because a drunk driver or what we call a looky-loo, somebody who's going to, do the rubbernecking and looking at everything and not paying attention to exactly what's ahead of them. So scan the scene, determine the extent of the incident. How far is your incident? How big is it? The number of people, the presence of hazards, power lines, leaking tankers, dangerous people on your scene. If it's a crash, visible hazards, or if it's a crash scene or a crime scene, fallen electrical wires, traffic. Traffic's watching the accident. Traffic's not watching you. And you're focused sometimes in on the accident and you're not focused on who's around you. Spilled gasoline. Nothing is worse than having some idiot come walking up with a lit cigarette and you've got gas fumes all over. Unstable buildings. The weather. We've had instances where, especially out on Highway 60 going to Lake Wales where they have the cow pastures, it's a raised roadway and it's a bad thunderstorm that comes through. Well, if you've got lightning hitting all around you, you don't want to be sitting there holding a giant metal rod or standing outside on a raised roadway with lightning hitting around you. It might hit you. And we've actually had units that have had to retreat back into their ambulance or their fire truck until the weather passed over them. Crowds. You always, always, always want to watch the crowds. Just because 911 was called does not mean that they actually want you there to help. Sometimes in a crowded situation or sometimes in kind of a lonely situation, you may be the target. There might not be an emergency call at all. But with crowds, you always want to watch. Watch for the people around you. What are they doing? Are they wanting you there? Are they not wanting you there? Some of your invisible hazards: electricity, biological hazards. Do you have someone who maybe has flown in from West Africa and they have Ebola? That happened in Dallas, Texas a few years ago. Hazardous materials. Rolling up on the scene and finding out, oh, I'm not dealing with just a respiratory issue or someone having difficulty breathing. It's because they got exposed to a hazardous materials and poisonous fumes. If you're seen as unsafe, keep everybody away. All you're going to do is gather more patients if you let people go in there. Determine your mechanism of injury or your nature of illness. Look for clues. The biggest thing to remember about mechanism of injury, it's going to be trauma-related. Trauma happens on the outside of the body. Nature of illness is illness. Sickness happens on the inside of the body. So we've got to investigate that a little bit. Look for clues. How did an accident happen? Is there a ladder that's tipped over and the patient was working on the ceiling and now they're laying unconscious on the floor? They can't tell you what happened, but you can kind of figure it out on your own. Ask the patient, the bystanders, family members, what was going on? Don't rule out any injury without conducting a full physical assessment. That'll get you in trouble. If you go, it seems okay, I'm not going to worry about it, that's the time that the patient will have a knife in their back and you missed it. Take your standard precautions. You should always have your gloves readily available. And I think I've already said that to you guys in class. There's no reason for you not to have a pair of gloves in your pocket or in your backpack. Consider whether use of additional protection. Are you going to need your glasses on? Remember, if you're coming to class or you're riding, you need to have your eye protection with you. Washing your hands. Get to a sink, wash your hands with soap and water as quick as you can. You can use the alcohol stuff also. Determine the number of patients. In other words, if you think you got more than one patient, call for backup. Ideally, if it's a critical patient, in the back of an ambulance, we only want one critical patient. There have been instances where they've taken 2 critical patients, but ideally, we only want one critical patient. In a mass casualty incident, when we get into triaging, that's going to become a huge issue. Do we have mass transit that can transport more than one patient for us? And which patients are going to be taken by ambulance and which patients are maybe going to be taken by a city bus to the hospital? That's all part of triage. So include your additional resources. Do you need more law enforcement on scene to control traffic? Do you need more fire apparatus on scene because you have maybe a vehicle fire or a house fire going on also? Are there power lines that need to be dealt with by the power company? And the wrecker. Are you going to need a wrecker operator out there to move a car so that you can get to a patient? Purpose of your primary assessment is to identify any life threats to your patient. Form your general impression. As you're walking up, start making a mental note of what you're seeing. What's the patient's sex? What's their approximate age? Do they look like they have any obvious bleeding? Is it a trauma or an illness? What's their level of consciousness? If you walk up saying, "Hi, how are you doing today?" and they completely ignore you, are they deaf or do they have an altered level of consciousness? When you are assessing the responsiveness, introduce yourself. Remember, be nice. "Hi, how are you doing today? I'm with 911. How can I help you? What happened?" If they can sit there and tell you everything that happened and everything that's going on, obviously their level of consciousness, or LOC, is good. If they look confused and they can't tell you what happened, they have an altered level of consciousness. Now, remember with AVPU, and you guys need to write this down. AVPU, alert, verbal, pain, and unresponsive. Alert, patient's talking to you, can answer all your questions. You walk up to the patient, their eyes are closed, you have to holler at them loudly to get a verbal response. That's verbal, you holler at them loudly. Okay, let's say you walk up to the patient, they look like they're asleep, you holler at them, you shake and shout, you can't get anything. Pinch their arm, pinch their inner thigh. See if you can get a pain response. An appropriate pain response is patient waking up or patient pushing your hand away. Sometimes you're going to have those patients that are not going to do any of those things. They're completely unresponsive. That's what we mean by AVPU. Now, going back to alert. The patient should be alert to person, place, time, and events. So they need to be alert to all 4 of those things. If there's one of them missing, you need to note which one. In other words, person. Hopefully they know who they are. Hopefully they know where they are. They might not know what happened to them, though. For instance, a head injury. You get somebody who gets conked in the head pretty good, they're going to be, hey, what happened to me? Why are you here? Well, you got hit in the head. How are you feeling? Well, I feel pretty good. Well, okay. Well, do you have a headache or anything? No. Why are you asking me about a headache? What happened? Well, you got hit in the head. Oh, really? They keep asking those repetitive questions, or you keep answering those repetitive answers. So obviously, they're not alert to what happened to them. When you're doing a rapid exam, we go from head to toe. We look at the face, we inspect the eyes, we check the airway, make sure it's open. Do we see any secretions? We could clear the airway. Do we put an airway adjunct in, like an oropharyngeal airway or a nasopharyngeal airway? And we'll get to those airways in a little bit. But doing a rapid scan should take you no more than about a minute, 30 seconds to a minute. We're assessing the rate and quality of breathing. Are they conscious? Are they unconscious? Or do they have any foreign objects? Can we just open the airway with a head tilt, chin lift, or a jaw thrust? Assessing the circulation. Compare the carotid and the radial pulse. While we're doing that, we're also checking skin color, condition, and temperature. So check those 2 things. If the patient has a really fast carotid pulse and no radial pulse, boom, right off the bat, I know my patient's in shock. Now I need to figure out why they're in shock. What's causing the shock? What's their skin color, condition, and temperature? Is it warm and dry? Is it cool and moist? If it's cool and moist, again, patient may be in shock. Warm and dry, patient probably has a good blood pressure. What does the skin look like? Is it pale or whitish kind of looking? Is it flushed or red? Is it blue? Blue is always bad. And yellow is indicating your liver problems. Or is it normal? Do they look normal like you look every day? What is the age and sex of the patient? What is the chief complaint? And when we say chief complaint, we don't ask the patient, hey man, what's your chief complaint? We go, what seems to be the problem today? Get the patient to describe to you what's going on in their words. Don't allow a conscious patient's comments to distract you. Focus on what the problem is. Get a good history. So part of history taking is sample history, signs and symptoms, allergies, medications, last oral intake, past events, and our events leading up to our past medical history. Now, when we are getting some of this information, we need to know, does our patient have any serious injuries or illness? Have they had anything in the past? What kind of prescription medicines? Are they taking over-the-counter herbal stuff? We need to note that also, because sometimes a patient may be prescribed something, but what they're taking over the counter as a vitamin may counteract what they're doing. They may have allergies to something, even foods. Sometimes we may give a patient a medication. That medication has some kind of food enzyme in it that can make the patient have an allergy. So obtain a sample history. So signs and symptoms, allergies, medications, past medical history, last oral intake, and events leading up to. That's a real quick way for you to make sure you get everything. With a sample history, the one thing we need to remember though, if it's a trauma patient, it's going to be pretty obvious everything you see. If it's a medical patient, we're going to have to investigate it a little bit harder under the signs and symptoms. We may have to throw in there something called OPQRST. So onset, provokes, quality, radiates, severity, and time. That adds to when it's a medical patient. Your secondary assessment, when it's done, that's looking for any kind of non-life-threatening things. So rapid assessment, we took care of life-threatening problems. Secondary assessment, we take care of non-life-threatening problems and conditions. Now, one thing that you can use, there's 2 acronyms that you can use. One of them is DOTS, and when we say we're doing our secondary assessment, we're looking for DOTS or we're looking for DCAP BTLS. So DOTS is deformities, open injuries, tenderness, and swelling. If you tell me when we're doing a scenario that I'm looking for DOTS, you better be able to name DOTS. If you tell me DCAP BTLS, you better be able to name it. So deformities, contusions, abrasions, punctures or penetrations, burns, tenderness, lacerations, and swelling. So either DOTS or DCAP BTLS. With your secondary assessment, you're doing the entire body, whether they're conscious or unconscious. If they're unconscious, consider stabilization of C-spine. So holding C-spine and doing a full body splint or putting them on a spine board. Examine a specific area that the patient sustained non-significant mechanisms of injury. Focus on that area if it's part of their chief complaint, but don't let it distract you. Just because a patient has a broken leg doesn't mean that's their problem. They may have a whole host of other problems that can take their life more so than the broken leg. Your respirations. Adult resting respiratory rate is 12 to 20 breaths a minute. Count their breath for a minute or 15 seconds and multiply it by 4. We're looking for the rate, rhythm, or the rate and the quality. The pulse. We're looking for the rate, rhythm, and force. Always take a radial pulse on a conscious or an unconscious patient. Compare the carotid and the radial pulse. Look at capillary refill. Now, capillary refill is where you squeeze the fingernail, and if you do it right now, squeeze the fingernail and look at your fingernail while you're squeezing it, and you're going to see that it's kind of blanched out white. If you let go, you're going to see it goes back to pink. That should happen in less than 2 seconds. If it takes greater than 2 seconds, the patient may be in shock or their hands may be extremely cold. The blood pressure. Systolic blood pressure is the force exerted on the walls of the arteries when the heart contracts. Diastolic is the same thing, but when the heart relaxes. If a patient has hypertension, their blood pressure always remains greater than 140/90. So that's when a patient has hypertension. The thing about hypertension is you need to keep in mind, if I have a patient who just got in a fight with somebody and their blood pressure is 140/90, doesn't mean they have hypertension. It means they got in a fight and they're amped up. Let's wait a few minutes, let them calm down a little bit, and now check their blood pressure. See what their blood pressure is going to be. If we can't hear the blood pressure or it's too loud in our area, we may need to palpate the blood pressure. Remember, palpating is feeling, auscultation is listening. We're also checking the skin color, condition, and temperature. Normal body temperature, 98.6. Okay, are they hotter than that or are they colder than that? What's the pupil size? Those pen lights you have, you shine them into the pupil and you see does the pupil react. If it's bright outside, their pupils are going to be pinpoint. If it's dark outside, their pupils are going to be big. Either way, you should see the pupils changing. If the patient's had a drug overdose or something, you shine a light and it stays big, obviously they've taken something that's a depressant. If it's dark outside, you shine a light and the pupil is pinpoint and it stayed that way, obviously they've taken something that is more of an amphetamine. They may also have a stroke or even a head injury. Sometimes you're going to see a patient with a large pupil and a small pupil. That means the patient probably has a head injury going on. And this is what we're talking about. Pupils should be midpoint usually. This is midpoint. The middle one, is dilated. The last one is pinpoint. Again, checking that pupil size. Level of consciousness. Again, use the AVPU, alert, verbal, pain, or unresponsive. Repeat the primary assessment. When you repeat the primary assessment, you're repeating your ABCs and the level of consciousness. Maintain that open airway. Reassess your patient's vital signs. Nothing looks worse than you going, yeah, patient's fine, this was their vital signs, and now they're 0 because they died. So notice when those things happen. Reassess the chief complaint. Maybe the patient thought of something after you fixed whatever their problem was. Reassess your patient. If it's stable, every 15 minutes. If they're unstable, about every 5 minutes. Part of your handoff is going to be age and sex of the patient, history, patient's chief complaint, level of consciousness, how you found them, status of their vital signs, and what was the results of your secondary assessment. Make sure any pertinent medical history, perform your sample history. If you need to throw OPQRST in there also under sample, do it if it's a medical patient. What was the response to the interventions that you did? Okay. Patients can generally be classified in 2 main categories, those with sudden illness or those with trauma. So think of nature of illness, or NOI, with sudden illness, and sustained trauma as mechanism of injury. When you're examining your patient, do your basic assessment sequence. Avoid jumping around if you can. Avoid jumping to conclusions if you can. That's why we have to listen to what our patient is telling us and watch what we find. Again, patient assessment, make sure you do your scene size up, primary assessment. Make sure you do your secondary assessment, and make sure you reassess your patient. Reassess. Every 15 minutes for a stable, every 5 minutes for non-stable. Okay, which of the following steps might be performed during the scene size up? Think about it. There's your answer. The goal of the primary assessment is to, and there's your answer. After performing a primary assessment and treating any immediate life threats, you should next. All right. You guys make sure that you get your workbook and your packets done, and we are going to be doing patient assessments in class. Thank you.